I'll be talking about something very basic, how to do a orbital biopsy. Infiltrative tumors that are not amenable to complete excision are taken up for orbital biopsy, especially if excising a tumor would have a functional deficit. And this is what the literature says. 8 to 20% of orbital biopsy result in non-specific or misleadingly wrong diagnosis. And the main important reason is that unrepresentative sample or non-uniform pathology. Suppose a tumor is variegated in terms of its morphology, such as lymphoproliferative tumors are known to have variegated morphology. One part of it may be atypical lymphoid hyperplasia, one part may be benign lymphoid hyperplasia, and one component of it can be lymphoma. We all know that. So in such a situation, if you take biopsy from an unrepresentative area, then that could result in a misleading diagnosis. So what we do traditionally is that all orbital biopsies, we do a multi-layered approach. That means that we take the superficial biopsy, a mid-zonal biopsy, and a deep biopsy, which goes beyond the epicenter of the lesion. Example is this young child who has a superior orbital mass. That is what you see. This we thought was a round cell tumor, and we took biopsy from all the layers. The yellow zone is the superficial zone, this is mid zone, and this is the deep zone, and you can see that it has crossed the epicenter of the lesion, and epicenter is judged by imaging. This is superficial, mid zonal, and that is deep. Now let's look at what the superficial zone showed. It showed only inflammation and fibrosis, which means that if I were to biopsy it only from the superficial part of it and said that that is the end of biopsy, I would get this diagnosis, which is misleading, which means that I would have treated the patient with steroids, nothing else. Round cell tumors partially regress with steroids, but do come back. So that would be a misdiagnosis and mismanagement. Now let's see what the deep biopsy showed. It showed embryonal rhabdomyosarcoma. So why did the superficial biopsy showed inflammation and fibrosis? Because we know that round cell tumors induce inflammation that results in tissue reaction, and that you biopsy from the superficial part. So if you mistakenly biopsy just the superficial part, you may end up doing that. Sometimes round cell tumors also have central necrosis. Because they so grow rapidly, they overgrow their blood supply and have a central necrosis or a cavitating necrosis. That can be biopsied and that can be interpreted as necrosis. Now this is a patient where there was a painless proptosis of the right eye, diplopia and upgaze. You can see that his superior rectus LPS complex is thickened. Here superficial biopsy showed lymphoproliferative lesion, and it was interpreted as benign reactive lymphoid hyperplasia by two pathologists. That's the kind of polyclonality we found, which is consistent with benign reactive lymphoid hyperplasia, whereas deep biopsy showed extrazonal marginal zone lymphoma, and he also had mediastinal lymphoma. So this patient, again, we could establish the diagnosis, correct diagnosis, by going for a deep biopsy. And this was confirmed on IHC. This patient was treated with external beam radiation and chemotherapy and is doing well. Now this is a patient where there is swelling, redness and pain of 8 weeks not responding to antibiotics. In the left eye, you can see it is congested, looks like inflammation, and there is a cavitary lesion right there. Superficial biopsy showed minimal fibrosis and inflammation. Deep biopsy showed xanthogranulomatous inflammation and necrobiosis, and confirmed the diagnosis on microbiological staining as orbital actinomycosis. So this patient has inflammation and xanthogranulomatous changes secondary to an underlying orbital actinomycosis, which responded to antibiotics, and this patient is doing well. This is a patient with bilateral lesion. You can see a large left orbital lesion and a smaller right orbital lesion with some amount of thickening of the extraocular muscle as well. Very confusing case with telecanthus also. This was acquired telecanthus. Here superficial biopsy showed inflammation and fibrosis. Deep biopsy showed granulomatous inflammation and multinucleate giant cells, and GMS stain showed fungal granuloma. So this was a patient with fungal granuloma of the midline extending to left as well as the right orbit. That resulted in this kind of a clinical appearance, and is doing very well with antifungals. This is a patient with infranasal orbital mass, proptosis and diplopia for 2 months. Superficial biopsy, as always, shows inflammation, fibrosis, and minimal necrosis. Deep biopsy showed perivascular granuloma, And it also had vasculitis and perivascular inflammation, and it was finally confirmed a case of vaginous granulomatosis, and this needed intensive therapy. So putting all our cases together, this is the summary of, I am not presenting data because this is a very short presentation, but we are actually working on this data. Pediatric adult round cell tumors, peripheral zone shows inflammation with fibrosis. It is the intermediate zone, the red zone, that generally shows the tumor, and deep zone often has some amount of necrosis. So you have to biopsy all the layers. Lymphoma, peripheral zone may show benign or atypical lymphodyplasia, and the intermediate zone, especially if it's a lacrimal gland lymphoma, shows the tumor, and deep also shows the tumor. If it is granulomatous inflammation with non-infective etiology, deep lesion classically has characteristics of specific etiology, rest of it could just be fibrosis. Fungus, deepest part of the lesion has the material that can be stained and microbiologically diagnosed. Again, tuberculosis has deep biopsy positivity. So this was the data that we had earlier analyzed, where we found that at least in 12 patients it made a difference. Out of 83 patients where this multi-layered biopsy was analyzed, in 12 patients it changed the diagnosis, and in 7 it affected the overall management. Certain other rules that you have to, when you do a biopsy, you have to give a steroid washout. This child had bilateral preseptal masses. Somebody had treated him on steroids with partial resolution, and when we did steroid washout, his lesion increased in size. If you were to do biopsy when the patient is on steroids and off steroids for a very limited number of days, then you would not get the diagnosis of AML. This patient again was diagnosed as myositis, elderly individual, and was on steroids. Initial biopsy when he was on steroids was negative, it just showed fibrosis. We gave a steroid washout of 3 weeks and repeated the biopsy from the extraocular muscle which was involved, and that was a extraocular muscle lymphoma. This was a patient with lacrimal gland lesion in both eyes, and on biopsy she showed Sjogren's. Right eye, of course, had later, after washout, when the second biopsy was done, showed lymphoma. So there are many cases like this. I don't have, I think, time to show all this. But in conclusion, I would just say that deep biopsy is very important in diagnosis of orbital lesion, and you should always go for layered biopsy and submit each layer to the pathologist. I would go to the epicenter of the lesion and beyond, guided by radiology for a biopsy. And the depth is always estimated based on CT or MRI. Always do microbiological tests and special stains, and also send for PCR or keep sample for PCR if you're in doubt of a infective etiology. And if you really are in doubt, you can also take the help of a pathologist in getting a frozen section intraoperatively done, or squash and imprint, which give you the diagnosis in about 10 to 15 minutes while you hold the child under anesthesia or the patient under anesthesia. Thank you so much.
Sir, in one of your cases, it was acute leukemic case. In such scenario, if our radiologist may misdirect us, in such scenario, can we believe on blood picture? Like
Absolutely. Absolutely. If a blood picture is indicative, that is perfectly all right. But when systemic steroids are given, peripheral blood smear is rid of all circulating abnormal leukocytes. So you again have to give a steroid washout to get the hematological diagnosis correct.
So we can stop at least for 3 weeks, or is there any
Ideally 3 weeks. Ideally 3 weeks. But if the systemic condition is deteriorating, you can do it at 1 week, and if that comes negative, you have to repeat it. You can't just say that, well, I have done the biopsy, it's negative, and the patient doesn't have leukemia. That cannot be justified without a 3-week washout.
Next, one question regarding one question is a fungal mass with little bone destruction. Is there any possibilities to our radiologists may misdirect us as a mucosal?
Yeah, radiologists can miss fungal mass, especially if it is an immunocompetent patient and there is more of desmoplastic activity. It may actually look like a sclerosing variant of non-specific orbital inflammation. In fact, Devraj published a sclerosing variant of tuberculosis presenting with enophthalmos, which looked like, something like a sclerosing NSOID. But when we did special stains, it did have TB bacilli deep within the lesion, and we treated the patient on anti-tubercular therapy. So these are possibilities. It can get missed clinically and radiologically, and biopsy is the only key. The more and more biopsies are done, more and more real diagnosis will become apparent.
Okay. So in such scenario, AFB staining also from our side,
Right.
if any suspicious
And we also
cases.
send the samples for PCR, fresh samples for PCR, as an additional confirmation. Sometimes they may not be able to find tubercular bacilli on staining, so you can depend on PCR with clinical correlation and radiological correlation. You can depend on PCR for a positive diagnosis and treatment thereupon.
As per your experience, which one better, AFB stain or PCR?
I don't know this. I can't answer this question. I would leave it to the experts.
Yeah. Sir, can you tell me which one should we, suppose there's a bone destruction, we have some cases, in such cases, straight you can go for a stain or PCR.
No, we are not proper people. I would leave it to, we have expert microbiologists, we would leave it to them. We would just tell them that we are suspecting this infection, this is the possible diagnosis, and they will do their best. You know, they have a battery of tests. These days, microbiology is very advanced. It's not just limited to ZN stain. So they would do whatever that is possible to get us or rule out the diagnosis. Rule in or rule out is their responsibility. Absolutely, yeah. If you simply can't send them a sample and expect them to pop out a diagnosis, you have to tell them what we are looking for and they'll look for what you're looking for.
So just one question for you, sir.
Both the ZN stain and the PCR both may be negative.
Sometimes, yes.
But your bony this thing, destruction, bone destruction, the sclerosis of the bone.
One of the big clue.
And
Yes,
the
clue.
patient's symptoms and history, all those things will find.
So I just have one question, sir. When you do that multi-layered biopsy, whether superficial and deep, do you take it from two different sites, one superficial and one you try to go
From
real
the
deep?
same site. From the same site, you go deeper.
Okay.
Cryo-assisted
Can't we
biopsy.
just do one single biopsy from superficial
You can
to
do,
deep?
but you know, it's very difficult to reach with the instruments that we have so deep. And the deepest biopsy then in that case will be very tiny, because if you use a Bart Parker knife and go around the ice ball, you always use a cryo-assisted biopsy. It will be in the form of a cone, and the deep biopsy will have very limited material. But if you go in the fashion of a cylinder with superficial biopsy almost equal to the mid zone, almost equal to the deep, then the pathologist would get enough samples. The only reason where only indication for bilateral biopsy would be bilateral lacrimal gland masses.
Okay.
In fact, that is the ASOPRS criteria. If a patient has bilateral lacrimal gland mass, then one eye could have benign reactive lymphoid hyperplasia and the other orbit could have lymphoma. So that's an indication for bilateral biopsy, despite having similar lesions morphologically in
So
both.
what do you mean by a cryo-assisted biopsy?
Cryo-assisted biopsy is that, when you have a vascular lesion, especially when you're doing biopsy under local anesthesia, if you simply make an incision within the lesion, it will start bleeding.
Exactly.
And also you cannot hold the lesion with forceps because then they will have artifacts, crush artifacts. So we use a cryoprobe, 3 millimeter cryoprobe, and freeze the lesion, and around that we make the cut. Cryo actually temporarily anemizes the lesion because it causes constriction of the blood vessels. So when you cut around the ice ball, cryo is holding the lesion, so you're not holding it with forceps. And because you're cutting around the ice ball, there is minimal bleeding. Then you use the same cryoprobe to go a little deeper and a little deeper.
Okay. Okay. Thank you, sir. Thank you.